Borderline personality disorder can be seriously disabling and often takes a huge toll on the individual. Many people with BPD have experienced some form of physical, emotional or sexual abuse in childhood. People with BPD are amongst the most likely to use mental health services. The NICE guideline contains lots of recommendations about how care can be improved, but the experts who wrote the guideline have chosen 9 areas of priority, and within these there are key recommendations that they think will have the greatest impact on care and are the most important priorities for implementation. There is a general consensus that there are not enough services for people with personality disorder, and access to services may not be good for people of black and minority ethnic groups. Service users feel that specialist services are most effective in treating personality disorders, and that it is important to recognise that treatment may need to be long-term. Early intervention is crucial in preventing a major deterioration in the disorder, and having the option to self-refer could prevent unhelpful and negative experiences. People with BPD should not be excluded from any health or social care service because of their diagnosis or because they have self-harmed.
Well, yeah, come in.
Hi.
Ah, Sophie, welcome back.
Hi.
How are you doing?
Not great at all. Really struggling.
What's going on?
I just feel awful all the time and can't seem to stop self-harming, and things at home feel really horrible, and really finding it difficult.
Not too great.
No.
It's about a week since you were last here, and we gave you some promethazine to help you sleep a bit.
Yeah.
Yeah, and has that helped at all?
It's helped a bit. I'm sleeping a bit better, but I'm just really struggling to manage, I think. Yeah.
I am. This sounds like it's a bit of a crisis at the moment.
Yeah, it feels that way.
Yeah. Why are things so difficult at the moment, do you think?
I think it started when my dad turned up at the house.
Right.
It made things a bit crazy at home.
God. He's not been around for years, has he?
No.
What, has that made things feel worse at home, or that? Is your mother around at the moment? Is she any support for you?
She's not really that great. She's quite low.
Is she?
Yeah.
She's got her own problems, of course.
Yeah.
I mean, you come from a pretty chaotic sort of family background, don't you? And with everything when you were young, you've had a hard time, actually. But you're harming yourself, you say. That's quite worrying. What are you doing? Are you taking pills, or?
Yeah, I'm cutting myself.
You're cutting yourself?
Yeah.
I mean, what's going on? What are you thinking?
I don't really know. I just get this feeling that I need to cut, and I just have to. I don't feel like I can control it. It just and I worry that I'm going to go mad, and
yeah. Your thoughts all rushing and jangling.
I just can't stop it. It just
And do you want to do worse to yourself sometimes? Yeah. So you're quite a risk to yourself at the moment, really. Yeah. I think you've got one of these sort of long-standing emotional problems that are difficult to treat, really. I mean,
is that kind of like I read on the internet? That it was something personality disorder or something. I couldn't understand whether some things said that it was kind of untreatable and that I might end up in prison or in hospital, and other things said, oh well, yeah, you can get help and talk to people about it. I
mean, one thing for sure, I mean, I've known you and your family for years, Sophie, and you've never been a risk to anybody else, and you've never done anything illegal as far as I know. So I don't think you're going to be somebody who's likely to go to prison, but they have done a lot of research on these things lately, and there are new ways of treating them, I think. So I think what I'll have to do is ask our very nice lady doctor, Dr. Dickinson, who's very helpful with people with mental health problems, and she would really know what the next stage of things to do is. I think it's probably more than we can manage with just a bit of medication here in the surgery. It sounds like it's a real trouble for you, but we will be here to offer you support, yeah? And I'll make sure that we make that referral as quickly as possible, and Dr. Dickinson can see what other help's on offer. Is that okay?
Okay.
Okay.
Being able to have choice about services and treatment is important to people with BPD and increases the service users' cooperation and engagement. When working with people with BPD, it is important to explore treatment options in an atmosphere of hope and optimism, explaining that recovery is possible and attainable. It is also essential to build a trusting relationship, to work in an open, engaging and non-judgmental manner, and be consistent and reliable. Staff need to bear in mind that many people will have experienced rejection, abuse and trauma, and will have encountered stigma. That is often associated with self-harm and BPD. Healthcare professionals need to be consistent in their assertion of boundaries and willing to commit time to clients. Leaving a treatment or service is often difficult for people with BPD. Withdrawal and ending of treatments or services and transition from one service to another may evoke strong emotions and reactions. A structured approach to endings is needed.
Hi, good morning. I'm Dr. Dickinson. Sorry to catch you. Right, you're Sophie, aren't you? Well, you've been referred by your GP. Why do you think you've been referred?
My GP said that you might be able to help. Things are a bit worse lately and I'm not managing too well.
What does manage mean?
Most days is pretty difficult because things are difficult at home and cutting more and there's a lot to sort out. Mum's not well at the moment either and so there's a lot to do at home and manage the house and stuff.
Sorry, excuse me a second. Hello? Yeah? I've actually got someone in with me at the moment. Okay, thank you. Sorry about that. Sorry, you were saying. Carry on, please.
No, it's right.
No, well, I need to know, I'm trying to do an assessment, what were you saying? Just carry on with this.
I was just saying that it's difficult at home.
You keep saying difficult, but I don't quite understand what you mean. Do you sleep at night? How's your sleeping?
A bit better since my doctor gave me some medication to help me with that, but...
So do you have trouble getting to sleep, or are you waking up?
Yeah, I have trouble getting to sleep.
Right. And what's stopping you?
Well, I'm just not feeling great. Thoughts, mood, just the usual stuff.
Do you hear voices or anything like that?
Are yours at the moment, all right?
I don't think you should. Well, I mean, normally we would be sort of trying different medications out to see what.
I don't want any more tablets.
Well, they've actually been proven to be quite useful in the past. I mean, have you taken
They've not
anything?
helped me.
Why do you think they haven't helped you?
I don't know. You should be able to tell me that.
Well, I mean, all I can suggest is that I can try and arrange an appointment with the complex needs service, but I don't do that kind of thing here. So, what do you think?
Is it going to help?
I think it could be very, very effective. Yes. I mean, does that sound like something that you would be willing to go to?
Yeah.
Community mental health services should be responsible for the routine assessment, treatment and management of people with BPD. The need for psychological treatment, social support and occupational rehabilitation or development needs to be considered. It is also important that the needs of any dependent children are assessed. Teams working with people with BPD should develop comprehensive multidisciplinary care plans in collaboration with service users and their family or carers where this is agreed.
Okay, Sophie, do you know anything about us, about what we do?
No, not really.
Well done for coming here. We have a preparation phase where you come along for 1 day a week and we get to know you and look at your problems and goals and what therapy that may suit you. Throughout the course, you choose how you behave, how you work, how you get along. A lot of the work is down to you. Because you come along to the therapy groups, you're not going to magically get fixed. It's a lot of work, and there'll be ups and downs. It's teaching you how to cope, how to deal with your problems in ways where you don't need to self-harm. I understand that's where you're coming from.
Yeah.
Yeah. You'll be working with a group of people who all have problems, be it dietary problems, self-harming, alcohol, drugs. And the idea is that a certain amount of your therapy comes from the group itself, because they are experts by experience. They've been there, they know how you feel. So you're not just dealing with a professional, you're dealing with other people that are aware of how you feel.
So do people manage to stop self-harming then?
Yes. Not everyone. Some people don't go through the course. But it is very much, we provide you with the toolbox and tell you how to use the tools. And after you leave us, you're more able to deal with problems that you have.
So, does it work?
Yeah, I've seen it work. And it works differently for different people. The outcome can be different. It depends on how much you want to put into it and how hard you choose to work.
So there really are things out there for people like me.
Yeah.
'Cause I
Absolutely. You're not on your own. This is one of the big things about coming along to the therapy, is you find that you're not on your own.
What happens when I finish?
A couple of months before you finish, the group will go through with you and talk to you about the leaving process, which can be quite awkward. I mean, these people become almost a family, and so you're moving on. It can be quite traumatic. And not just for you, but for them. They're losing you from the group. The dynamics have changed. So you're moving on, they'll help you with what you want to do, whether it be employment, further education. You may find that when you come out of the service, that you can go back to your GP, you won't need the mental health service anymore. And that's fine. But we are here if you do need us, and if not, we wish you luck. How about we make another appointment in 2 or 3 days? And you come back and let me know what you think. Sound fair?
When providing psychological treatment for people with borderline personality disorder, especially those with multiple comorbidities and/or severe impairment, the service should have an explicit and integrated theoretical approach, which is used by the treatment team and which is shared with the service user. It should also provide structured care in accordance with this NICE guideline and have suitable provision for therapist supervision. The frequency of specific psychotherapy sessions should be adapted to the person's needs and context of living, and twice-weekly sessions may be considered. Brief psychotherapy interventions for less than 3 months are unlikely to help for BPD or for the individual symptoms of the disorder. Drug treatment should not be used specifically for BPD or for the individual symptoms or behaviour associated with the disorder. Specifically, antipsychotic drugs should not be used for the medium and long-term treatment of BPD, although drug treatment may be considered in the overall treatment of other coexisting mental health conditions. Short-term use of sedative medication may be considered cautiously in a crisis. The duration of treatment should be agreed in advance, but should be no longer than a week. Polypharmacy, or the prescription of multiple different medications, is not recommended, and for those who do not have a diagnosed comorbid mental or physical illness, the aim of this should be to reduce and stop unnecessary drug treatment. Mental health trusts should develop multidisciplinary specialist teams and/or services for people with personality disorders. These teams should have specific expertise in the diagnosis and management of borderline personality disorder, and should be able to provide assessment and treatment services for people with BPD who have particularly complex needs and/or high levels of risk. They should also provide consultation and advice to primary and secondary care services, and offer a diagnostic service when general psychiatric services are in doubt about the diagnosis or management of people with BPD. Also, they will need to develop systems of communication and protocols for information sharing among different services, including those in forensic settings, and collaborate with all relevant agencies within the local community, including health, mental health, social services, the criminal justice system, CAMS, and relevant voluntary services. Multidisciplinary specialist services should also work with CAMHS to develop local protocols to govern arrangements for the transition of young people from CAMHS to adult services, and ensure that clear lines of communication between primary and secondary care are established and maintained. They should be able to support, lead and participate in the local and national development of treatments for people with BPD, including multi-centre research. They would have a useful role in overseeing the implementation of this guideline, including the development and provision of training programmes on the diagnosis and management of BPD. They could also usefully monitor the provision of services for minority ethnic groups to ensure equality of service delivery.